would be held in London and with a practical hands-on session. However, we are very grateful to Karen for agreeing to present in an online format that is possible at this time. Karen's professional training and experience are shown on the accompanying slide. I hope you can see that. I would request all participants to please unmute. Oh, sorry, to mute their microphones because we're getting a lot of background. On a personal note, I would like to say that Karen is a passionate champion of her cause with a growing following at conferences, courses, and online. Through her hard work and determination in promoting ultrasound-guided FNA, she is a source of inspiration to pathologists who wish to undertake this in their clinical practice. The number of almost 350 registrants at today's meeting, I think, bears testimony to the level of interest in the topic and also Karen's influence and reputation. So Karen will give a talk now for about 30 minutes. And then we'll have a discussion based on the questions that you type into the chat box that Alison and I will be monitoring. And then this will be followed by a slide seminar with ultrasound and cytology images and with polling questions to keep you all engaged. And then we will pick up, as I say, any comments and questions through the chat boxes, both at the end of the talk and also at the end of each case presented in the slide seminar. I would also encourage everyone to live tweet about today's presentations and discussion and tag in US FNA_Spain and also British Cytology. So without any further ado, Karen, welcome and over to you.
Thank you very much, Ash, for this introduction. And thank you very much for the invitation. Welcome everyone to the session. Thank you for being here with us. And thanks to the BAC for this invitation and the opportunity of being here with you. I hope we will have a good time, at least, and during the session, and that it will be of interest of everyone. I will share my screen. And without any further delay, let's start. This will be our program this afternoon. We'll be speaking about a few topics in interventional pathology. So let's get started. Let's start with what is interventional pathology. So we think about interventional pathology as a new branch of pathology that allows us to perform ultrasound-guided procedures to ensure optimal tissue sampling for faster and confident diagnosis. But we like to define our field of work as a convenience store. You can select only the items or techniques you are interested in and come back if you want more. So according to David Liu, who is part of the CAP course where I was trained, and he was the one with, sorry, okay. And he was the one with whom I did my first phantom ultrasound biopsy training. He says interventional cytopathology is one of the most interactive specialties in pathology in terms of working with patients. So he has a lot of experience in interventional and also very nice papers in this area. But the first known report of the interventional cytopathologies is from Dr. Gross, advocates that the entire FNA process should be done by the same person. And this comes next. What does an interventional pathologist do and not do? Isn't that the radiologist's job? So we don't do radiological diagnosis, just focus. Ultrasound diagnosis, that is the work of the radiologist. We only ensure sufficient and representative sample with fine needle aspiration. We also use ultrasound to obtain information, make real-time decisions, and also guide the needle. We also perform rapid on-site evaluation, assessment of the lesion, and we work as a team, always as a team. Also, we perform other procedures, such as corneal biopsy, punch, or tissue marking if needed. This is something very important to remember. The main goal of US FNA is to actually make a diagnosis, not merely put the needle inside the lesion, because the easy part of the process is actually to get to the lesion. The difficult part begins with the sample on your hand. You have to know how to handle the sample in order to make a diagnosis. So what we do every day is combine our knowledge of tissue and cell handling and diagnostic with point-of-care ultrasound expertise and the ability to obtain an ultrasound-guided biopsy samples. This results in a powerful hybrid capable of making real-time decisions that improve the efficiency of the technique. So, focus is not hocus pocus, according to this guy, but you don't have to believe him, but he's right, because point-of-care ultrasound is what it is focus. This author says, stop listening and look, but we say, don't stop palpation, but learn to look. Because focus is just a macroscopic exam, on screen, real time, on site. According to the definition, it's an ultrasound for diagnostic orientations or to perform procedures. We will not make radiological diagnosis, only aid the cytological and tissue diagnosis. It does not replace the diagnostic ultrasound. Another definition refers to the use of portable ultrasonography, like these devices, and all of them are portable nowadays, the pocket size and the bigger ones too. This is a review article from New England Journal of Medicine about focus, and the ultrasound scan has left the radiologist office a long time ago. This article mentions many medical specialties that are using focus right now. So why stay on the outside if we can use it too with the interventional pathology? This article shows that we are now part of the focus family. There are reports now of ultrasound for pathologists. This is a David Liu article that precisely I recommend to read. And we also are a fundamental part of a test that is also part of the POC family, the FNA, because it's a test that is performed near or at the site of a patient with the result leading to a possible change in the care of the patient. This is point of care testing, and the FNA is a point of care testing. So now, how do I describe the findings in the report? Recall the importance of standardized reports for diagnosis in the USCAP in 2020. Freestyling is not recommended. So that's why we have suggested a standardized reporting protocol for interventional pathology reports. And in this protocol, we make it clear that we do not make an ultrasound diagnosis, only description of the findings, just a macro on screen, remember? So now let's have a look at the guidelines. In the curriculum for specialty training in histopathology from RCP, specifically in the section of DOPS, the performance of an FNA with targeting by palpation or ultrasound is contemplated. They don't say that it must be the radiologist, the one handling the ultrasound equipment. And if we go to the section on non-cervical cytology, again, it's contemplated to acquire the ability to perform a superficial FNA, and it does not say that the ultrasound guidance should not be done or cannot be used. Here in another note from my colleague Hector. Now let's have a look to the ultrasound training recommendations for non-radiologists. They have a syllabus for each anatomical region, and let's say in this case head and neck. Let's have a look at some key points. In the case of Spain, there is no medical intrusiveness as long as proper training is proven. So this appendix specifically refers to a competent physician, not a radiologist. Specifically, they mention an endocrinologist who performed FNA by palpation and who can, after completing a training program, acquire the necessary skills to perform the procedure with ultrasound guidance. And the question arises, why another specialty and not the pathologist? There's no reason. So they also suggest to do a formal report, and that is what we always do. This is the recommended syllabus for head and neck, and it is accomplished without any problem in all the training courses. So we all started from the beginning. Even the non-radiologist clinician who performs FNA and biopsy with ultrasound guidance, the pathologist, is no exception. Now let's talk about a few things about the role of ultrasound and avoiding the blind approach, as we usually like to say. When we have a pathological nodule in any part of the body, the ultrasound gives us valuable information to aid the diagnosis and allows us to perform diagnostic techniques. And this is the next logical question: when we should use ultrasound guidance? And the answer is always, because the blind approach means to disregard the benefits of the ultrasound guided biopsy. So the use of ultrasound is optional, or maybe optional, in case of very superficial lesions with curved edges that are difficult to scan with the linear transducer. So this can be solved with smaller footprint probes, specially designed for very superficial parts. Now, a big item: ROSE and one-stop clinic. We consider FNA as a classification test where decisions are made according to the findings. So it's harmless, it's safe, and the only real contraindication is that the patient says, I don't want to. In a more schematic way, we know this is how the concept is better explained. An FNA, like getting your hand into a puzzle box to retrieve pieces that will be placed on the smear preparation, and a corneal biopsy as extracting an already assembled sample from that puzzle. Therefore, if the sample is not properly handled, it's possible that we will not be able to make a diagnosis. So if we receive broken pieces, we can't imagine the complete puzzle. It's not possible. Or if we receive two or three boxes of pieces unnecessarily, it takes us longer to get to the full picture too. So normally this works this way. The patient comes to his treating physician and goes to an FNA by the service in charge in each hospital. But where does the sample go? To the pathologist. And if the patient requires a biopsy because the FNA is not conclusive or needs a corneal biopsy, he must return. And where does the sample go? Again, to the pathologist. And if we run out of sample because of IHC, let's say, must return. And this keeps going on. And where does the sample go again? To us. This is very time consuming, and this is valuable time for the treatment. How do we do to improve this workflow? Well, the patient comes to his doctor, and if he needs an FNA, he goes directly to our clinic where we do an FNA and corneal biopsy if needed through a real-time decision-making system, which is possible to achieve thanks to ROSE. This workflow allows to shorten diagnostic times and receive early treatment. This is what is called a one-stop clinic. The patient receives a multidisciplinary evaluation and the possibility of FNA and biopsy with also diagnostic approach during the same visit. We also call our colleagues after ROSE to give them the information we can provide to speed up the patient's appointments. This is the diagram we use in a summarized way for real-time decision-making in our practice. And the key point in the process is ROSE. This allows real-time decision-making, optimal sample handling and optimization of the tissue, and also giving the initial diagnostic approach. Now, let's talk about cell block 2.0. And please keep this term at all times at hand, because from now on, keep our minds open. Let's keep our minds open. This is do the same thing that has always been done in other ways to make it more efficient, interesting, attractive, call it what you want. It's to do the same as always, but in a different way. So if I were to tell you that these are basically similar gauge FNA needles, that they are used in the same way with the same ultrasound guidance technique, would you try them all? I'm thinking yes, but what if I said that this is the device of the left, which is a biopsy device, in this case wrongly called core needle because it's so thin. And as we see here, is the same position and the same needle plane. So here's a more graphic comparison, and it would basically be a cell block, but already assembled without juggling or doing magic to group some cells from one FNA and using the same technique of the ultrasound fine needle aspiration. There are many devices of different gauge and size, but they all have in common that there is a minimum point of entry of 2 millimeters from which we obtain a sample that provides valuable information for diagnosis. So the next question is, pathologists can perform biopsies? Of course, yes. This is the cell block 2.0. Here comes the idea of cell block 2.0. And this is what we can train in many ways, and we have it at reach. It's a relatively simple technique with little complications, the same technique as USFNA, and it can be trained in the daily practice on fresh organs, in phantoms, or also in autopsies. What are the benefits of learning this? Avoid open surgeries. The combined approach of FNA and corneal is also really great. Perform also many tests that are needed today for a proper diagnosis, tumor banking, and many benefits. But we can also can perform tissue marking with these devices because it's the same technique. So in a corneal biopsy, we also perform rapid on-site evaluation with an FNA, with a previous FNA, or also with tissue imprinting on the glass. And in our practice, every corneal has a previous FNA, but not the way around. Not all FNAs have a corneal biopsy. So this is an important question for us because the role of the pathology assistant, as it's called in North America, I think, we call them técnicos de anatomía patológica y citodiagnóstico. I don't know if it's the same figure as the BMS, but I include them in the presentation because in my case, she's my right-hand person on a regular basis, and she deserves all my recognition for her wonderful willingness to help. Although it should be pointed out that when she's not here, all of my PAs participate in the clinic in a very fluid way. The PAs acquire the necessary knowledge to become an essential part of the practice. They receive the patient, provide the informed consent form, enter the data into the ultrasound machine, select the most appropriate probe, prepares everything that's necessary, and also is able to handle cytological samples, assist the pathologist during the procedure, and also can train other PAs and give training courses. I think BMS can also have a potential role in this kind of practice. The PAs trained for this knows exactly what we need, even before we ask for it. And ultrasound also play a role in telecytology. Nowadays, through Bluetooth, it's possible to send images of the rows directly to the ultrasound screen with the mobile device directly from the microscope. Trained technicians or PAs can assess the sufficiency of the material of the sample and move forward in the appointment sequence. For example, it is adequate. If it's adequate, they could explain to the patient and disinfect the probe for the next one. Or the other way around, they send us a photo of the rows and we decide. It's always a matter of adapting and taking advantage of the possibilities we have at reach. Now, regarding pathologists perform ultrasound guided procedures, of course, there are some pitfalls. Not having the ultrasound scan images of the radiologist prior to seeing the patient is one of them, but everything is to adapt to the needs of each hospital and each pathology unit, and all of them have solutions. In this case, they are usually pretty much apparent nodules, not millimetric ones. The time I have to spend doing the procedure is another pitfall, but you would be surprised to know that in the end, it's not so much extra time. It's an investment because you have more information at hand to make decisions and reach a diagnosis. Also, getting an ultrasound may be a potential pitfall, but this can be solved with strategy. The one ultrasound machine that no one wants in the hospital, or a pocket one, or a shared one. And also, training is not a problem because we start from one or two fundamentals, and from there we go deeper. We all started with little or no knowledge at all. And also knowing the local guidelines, we have to turn the weaknesses of the diagnostic circuit of FNA and biopsy from our hospitals into benefits of having the new clinic in pathology. The list of the problems is the local guidelines, because you can also perform US guided procedures after short courses and following the recommended syllabus. Now let's talk about why it should be performed by the pathologist or having a pathologist on site at least, because it improves the efficiency of the technique. Many specialists can acquire the technical skill of placing the needle in the lesion, but according to David Liu and us, inserting a needle into a palpable mass is easy, but obtaining well-fixed, thin, evenly spread cellular smears that are diagnostic is a difficult part. So according to Dr. Sauer and his colleagues, ultrasound is medicine's new stethoscope, and we agree to that. Cytopathologists performing US guided procedures, they said, report adequacy, sensitivity, and specificity as good or as better than clinicians or radiologists. This is another big one on interventional, Dr. Abele. And he also says a pathologist US FNA is better because we have a great advantage, the immediate feedback. This is really underrated. And this woman is Dr. Susan Rollins, the one who trained me and teach me a lot. She says something, it's true. Experts make the procedure look easy and not at all complex. However, FNA, it's a complicated test, and accurate diagnosis can be impossible without a well-prepared slide with well-preserved cells in monolayer. Now, in summary, what means high-resolution diagnosis or one-stop clinic at the pathologist office? It means many advantages for the patient, for the treating physician, and all aimed to an efficient improvement in diagnostic times. However, for the hospital, the main advantages are related to a more efficient management of the appointments, staff, and resources. And this can be seen in terms of reimbursement, repaying or compensating for the investment of an ultrasound for the purpose of developing this practice. Now, where can I be trained? These are pathways for additional training, and POCUS Certification Academy is a good choice, a good option to gain knowledge in ultrasound. They have many programs, starting with the fundamentals in ultrasound, and they also have digital certificates that can be verified and shared on professional websites, such as LinkedIn or even Twitter. And this is the College of American Pathologists course. I highly recommended it. It's a 2-day course. This is where we did our own training, and it's a perfect option because it's designed for pathologists. And we also have been already teaching pathologists how to perform US FNA in Madrid for almost 4 years now. Also, during 2 intensive days. Well, we say that learning to put the needle into the nodule is easy. It's because it is that way. In 2 days, you can learn to do that or less. So the way to get started and our experience is you actually realize the actual goal of an FNA is making a diagnosis, and that's what we do. Then you realize that this can be learned in short courses. And then you do your first attempt on phantoms, and this is the easy part of the process, really. And then realize it's harder to handle the sample and make the right decisions with it. Well, now let's do our first US FNA. Well, now I'm curious about corneal biopsy and this cell block 2.0 technique because it's the same. So let's start with 20G. And from this point on, you will want more. Let's try 18, 16. Oh, I'm on fire. Let's try 12. And this is a mental process first, and then the local strategies, and then at the hospital and each pathology department. First, you have to convince yourself and then convince the structure to change. In our office, we work with high standards of patient care. We have a high-level disinfection system to guarantee a safe practice during these pandemic times. And this is a poster we presented at the last annual SEAP meeting in 2020, where we analyzed cases from 2018 to 2019 using real-time decision making. And we obtained 106 procedures, and in 78% of them, it was not necessary to perform corneal biopsy. However, in 27% of them, it was decided to perform corneal biopsy during the same visit. And in all the cases with corneal, we obtained sufficient and representative sample. So the use of POCUS will continue to expand among medical specialties. That is a fact. Whether we are part of it, it's our decision. So in summary, without ultrasound is going blind, but also without ROSE is going blind. So please avoid both blind approaches. This is an invitation just to leave the comfort zone or make it bigger, because magic happens out of the comfort zone. And finally, I would like to thank the entire USFNA team and all of you. Thank you very much for your time, your kind attention, for being here with us. And this is our contact information. We are always willing to help you and outreach within our social media and official channels. So
great, thank you, Karen.
Brilliant. Karen, thank you so much. That was absolutely marvelous, really lively presentation, and you know, all the GIFs and the video clips worked, so that's fantastic, you know, without any hitch. So congratulations on a very lively and interesting presentation. I have a whole sort of list of questions here, but we will try and cover as many as we can. I think we do have some time to do that. I'm taking them in a slightly different order to which they came in. So first of all, there was just a clarification from a colleague who asked whether the PA that you mentioned is someone from the laboratory, or is it somebody from the radiology department? Is that a radiographer? I think I know what the answer to.
No, it's from pathology lab. The thing is, they are called different names. In the US, they are pathology assistants. I think here in Spain, they are técnico superior de anatomía patológica y citodiagnóstico. I don't know if they're, I don't know, cytotechnology, maybe it's the same thing.
Yes, I think, yes, you're absolutely right. There are different sort of names. Cytotechnology or cytotechnologists, I think, is the most kind of accepted name in North America and across some countries in Europe. In the UK, they are referred to as biomedical scientists. And a pathology assistant in general, I think, is an individual who can also do like a histopathological cut-up as well. So, you know, there's also sort of training levels and grades that are available. So thank you for just clarifying that. There's another question about how many times do you recommend performing PAAF in a radiologically suspicious node?
to perform? I'm sorry,
Yeah, I'm not quite sure either. I thought maybe this was an abbreviation you might be
CNB, maybe corneal biopsy after an FNA in breast?
Possibly. I'm just waiting to see if the colleague who typed that in could perhaps put in the full form of PAAF. We'll wait and see. But
It
in
depends.
the meantime,
Depends on you mainly. This is the power of interventional, because if you are not quite sure about what you are seeing, you can recommend or do the corneal biopsy. If you have the certainty this is a benign or let's say malignant lesion, and you can and you can perform a diagnosis with what you have with FNA and cell block, a traditional cell block, well, maybe you don't have to perform corneal. This is your choice, and that's why we said at the beginning, we are like a convenience store. You come in, take what you want and what you need, and if you don't want to perform corneal at this time, then you start with FNA, and that's it.
thank you. Yes, somebody's just clarified that PAAF is the same thing as an FNA. I think it's
okay.
So, right, okay. But no, thank you very much for answering that question. I've got another one here. In a one-stop clinic, is any ultrasound imaging interpreted by a radiologist? If
Sometimes.
Not, right, okay. So for instance, for thyroids, would the pathologist give the radiological score, you know, the sort of TIRADS scoring system? Because you said that you don't interpret the radiology. Or do you give a TIRADS score?
At least officially. I mean, you cannot put your diagnosis, radiological diagnosis, in a report, but you can train in ultrasound and learn to recognize some features of the lesions. Not always they come to the consult with the ultrasound by radiologists, because sometimes they come with just the petition from the specialist. I don't know, and then you can decide if you perform the fine needle aspiration or wait to the diagnostic ultrasound and then call again the patient. My colleague Hector and Luis from Asturias, they have wide experience in thyroid and also in ultrasound of the thyroid. And I think if they have a patient which does not have the ultrasound by the radiologist, they can decide with knowledge if they can perform or not the procedure.
Thank you. And I think it kind of reflects the differences in approach across different healthcare systems. I think because there's other comments here as well about, you know, some of the challenges that colleagues face in the UK and in other countries in implementing, you know, pathologists performing ultrasound guided FNA. And so, you know, those obviously need to be addressed before, you know, we can reach the level that you are already performing at. So it's a kind of a step at a time approach, I guess.
Step, yes.
And some are pretty much sort of early on in that consideration or finding it difficult to get things off the ground. We'll perhaps address some of those discussions in the course of your presentation. I've got some other questions here as well. Very specific one, clearly someone who's quite familiar with the technique. The frequency for hockey stick transducers is high and recommended for superficial structures. Do you use two different transducers for superficial and deep-seated organs?
We are privileged ones because we have many transducers. I will speak just 2 words about this in the slide case seminar, but we use mainly the linear probe. This is the linear probe. This is our, I don't know, our most used probe. Well, we also have the one that is called, I don't know, hockey stick probe. This is also great for superficial parts. And I think it's a good choice too.
Excellent. Another question here about portable devices, to actually, you've said, what it takes to get training in ultrasound, targeting for an FNA or a core biopsy. Is there a sort of a beginner's way, by using portable devices? And if you're available, if these are available, what sort of price ranges these are in? And then also whether you integrate ultrasound images into your cytology report.
Okay, first one, the portable devices are a great option to start because of the portability they have. This is an ultrasound and this is my mobile phone. You can see the size and you can have this thing on your pocket, and you have not also the curved probe, but you can have the linear probe too. And you can have this in your pocket to train in yourself and train the normal appearance of the lesions in your neck, let's say that. And of course, they are a best choice regarding price than the bigger ones. The second question, I think, was...
not to worry, it was about, do you integrate your ultrasound images into the cytology report?
No, the integration, we are working on the integration right now. I just perform a description of the findings, like a macro, and I'm including these findings in the written report with the protocol suggested.
Excellent. Lovely. I think we have time maybe for just one more question, and then we can go on to the slide seminar. Someone's asking how many procedures you perform in a year.
It's been quite variable because the COVID turned down everything. But let's say, I don't know, 100 or so, because our hospital is not so big, and we are receiving mainly head and neck cases and soft tissue cases, metastatic cases, not cases, not benign cases at most, and thyroid are still working in the traditional workflow. So that's why we say this is adapting the practice to each hospital and each practice.
Absolutely. Well, you have to start somewhere. And so, I think having reached a target of about 100 procedures a year would be very good in terms of just, maintaining your own competence and expertise, and, to be able to say that you're doing sufficient numbers of them to gain confidence both in yourself and also for clinicians' confidence in the pathologist that they're, undertaking a sufficient number of procedures every year to maintain their skills. So I suppose in that, like, some sort of numbers.
Another thing is that we don't have exclusive dedication to this consult. We also do another things like myself, breast pathology and of-gene pathology and FNA and traditional circuit FNA and all of that. So all of that and 100 cases in a year, I think it's not bad.
It's great. It's absolutely great. I mean, we are talking about, histopathologists who also do cytopathology, and they may only have, a few hours in a week when they undertake any sort of cytology reporting, whether it's in the context of a clinic or actually just slide reporting. So that's a great number. I mean, I don't know what the recommendations are by, the CAP training, for instance, whether you should at least perform a minimum number of 20
they
or 30.
Have a minimum number. Yeah, I don't remember right now, but they have a minimum number also for renewing the certification.
Exactly. So I think those are all kind of, evidence of maintaining competence and expertise, but, 100 by all means is a staggering number. So Karen, thank you so much for the presentation and for taking all of the questions. There is one more question, but I think this is addressed about roles and the role of cytotechnologists, but we will be addressing those issues a little bit later in the program. But thank you for all the research and insight, that you have into the UK system as well for, sample management and also the kind of the curriculum for pathology trainees and non-radiologists. So thank you for looking into our system as well to make this talk relevant to us. We are ready now and looking forward to the slide seminar. So when you are ready, we should be happy to see your presentation.
I will share my screen right
okay.
now. Okay.
And again, for each of these questions, cases as they're presented, you can type in a question or two, but they will also be polling. So don't go away. Stay somewhere near your mouse where you can click on the answers.
The polling is just for fun. We are not giving any hard time to anyone. So I encourage you to participate.
Thank you. Okay, Karen, all yours.
Well, and now we will be talking about some clinical cases and point of care ABCs. Just an ABC. Now, let's start with this article by David Liu again, because it describes ultrasound basics and all needed to adjust the machine to optimize the appearance of the mass for biopsy. It's really worth reading. To understand this basic fundamental, the basic of ultrasound, let's say the ultrasound wave behaves like the light in the sea. It will reach to the bottom as long as it has the necessary features. So if the wave has a high frequency, the image looks very good at the top, but it's lost at the bottom. It does something like this. In the surface, you can see better than in the bottom, because the wave is attenuated. And on the contrary, if the wave has low frequency, the image loses details in the surface, but you can see more, you can see deeper, and we can see up or down according to our needs by selecting the most appropriate type of probe. There are many. Transducers are in charge of transmitting and receiving the wave or the sound wave. And there are different kinds of probes on the market to meet the needs depending on which part of the body is going to be scanned and the needs of every practice. I think you can see the arrow. This one is the hockey stick one, and this one is the linear probe. This is the one we use the most. And this is a very, very superficial lesion dermatologists use for skin ultrasound. Now, there are even pocket-sized probes with superb portability and very good performance for focus. Here we can see an FNA with this device that you can connect on your mobile phone, on your tablet, and even if it's Android or Apple. For the procedure, we can select two types of approach related to the long axis of the probe, the transversal or aeroplane one, or parallel or in plane. You may discuss the patient's medical history with the treating physician and plan the most appropriate positioning for the transducer, and also for the patient. Patient positioning is very important. Here we see it on a phantom device, a commercial one. You have to be very aligned with the mark on the probe and go through the beam imaging a triangle whose tip is our lesion. And this is what we will see, a bright spot or with a comet tail, like in this case, a comet tail. This image is the tip of the needle, or also can be part of the body, because we only see what is actually passing through the beam. And now in this case, the parallel approach, in plane approach, we will see the entire needle trajectory, as in this FNA case. Or here with the cell block 2.0, remember the same technique with a little twist. And as we already said, through a minimal incision. Sometimes also we paint the area of local anesthesia or the most convenient position for the probe as an aid. And let's start with case one. We brought 5 clinical cases, and if we have enough time, we will present them all. Otherwise, we'll have 4 of them. This is a case of a male patient, age 50, with left supraclavicular lymphoid aggregate. And this is the ultrasound image. He had multiple pathological lymph nodes. The largest, almost 3 centimeters. Now, if I show you this image and say this is normal ultrasound appearance for a lymph node, ovoid, bean shaped, with vascular ileum and regular margins, with these approximate dimensions, 1 centimeter, let's say. And now I show you this clip. What would you think? Could you say this is a normal lymph node ultrasound appearance? Of course not. This is the findings at Rose with atypical cells with some special features which reminded us of something we have already seen. Images like this one reminded to another kind of pathology. Now, let's do some polling for fun. Given the findings at Rose, what would you say? This is malignant, I recommend biopsy. This is malignant, that's it. I'm not sure. Or this is a lymphoma as suspected, because the patient had many pathological lymph nodes. They thought about lymphoma.
I'll give about another 15 seconds or so, Karen, for polling.
Karen, while the poll is being launched, there's a question that's come in about the lubricant that you use for the probes. What do you use, and does it cause a contaminant artifact on the cytology slide? Thanks.
Okay, that's an interesting question. We use aqueous chlorhexidine. Aqueous chlorhexidine, because we know we cannot use ultrasound gel, and if we use another kind of lubricant or something, we may damage the probe surface, this probe surface. So we use aqueous chlorhexidine.
Fantastic. So that's the pink fluid that we get used to seeing in the ultrasound room. And the results of the polls are back, Karen, and 65%.
Great results.
Can you actually see the results?
Yes, yes.
Okay, great. I'll leave you to comment on them then.
Okay, we'll be commenting them during the case.
Okay.
So can I just say that what the results are for the recording, because the poll doesn't come up on the recording.
Oh, please, Alison, please, yes.
Yeah, that's fine. So 65% said malignant epithelial neoplasm, recommend biopsy, 20% malignant, that's it, 6% not sure, and 9% lymphoma is suspected.
So after Rose, of course, you recommended biopsy, and that's what we did. We decided to perform a corneal biopsy. And what do you think about this so far? Did you identify some particular traits or have a preliminary guess? This was the color Doppler of the lesion. It was a highly vascularized lesion close to brachial plexus here. And other vascular structures. The ultrasound guide allows us to have precision in performing the procedure. The correct answer for us was to perform a biopsy, and this was the sample we obtained, and the correlation with cytology is great. I'm used to seeing abortion specimens because I see gynecological pathology as well, and this somehow reminded me of that. Let's go back to cytology. And here's some PAP features in advance that may be of use. Syncytial trophoblast-like cells. And look at the cell of the upper left, for example. And this is liquid-based cytology. So Now, what do you think about the findings? You see now the particular traits and a preliminary guess with these features on mine. What would you told me? This is the power of the combined approach of fine needle aspiration and corneal biopsy. The correlation is really great. The possibility of morphology correlation with two different views of the same pathology. Here's the HCG, and we diagnosed carcinoma metastasis with trophoblastic component, and given the positivity for HCG, we suggested to consider choriocarcinoma type tumors, testicular choriocarcinoma type tumors, and the primary testicular tumor with trophoblastic component was found. The ROSE evaluation allowed to provide an initial diagnostic assessment during the FNA, and this was a surgical specimen. Cytology, in this case, allowed to suspect choriocarcinoma features. The biopsy confirmed the findings with very positive HCG, but the definitive specimen showed only focal positivity in the vascular infiltrations and the necrotic component. It's important to identify the choriocarcinoma component because of the adverse prognosis related to it. This is the power of the combined approach. So for case number 2, we have a male, 49 years old, with cervical lymphadenopathy level 2 here at the neck, with suspected malignancy. We were having a very limited surgical shifts because at that time we were at the 3rd wave of COVID, and the previous FNA of this patient was negative, benign or reactive, but there was clinical suspicion for malignancy. This is a pathological image of a lymph node. Remember the normal appearance. Now you recognize the pathological pattern, not malignant, just a pattern, macro on screen. That's it. Now, this is the cytology, and we had this polymorphic pattern with these structures and maybe tingible bodies, germinal centers. We frequently saw these structures, many plasma cells and a clean lymph node background with no evident necrosis. This case, full dose in rows. Now, let's do some polling again, just for fun. Considering this image, what do you think about these structures? These are germinal centers, granulomas, this is a carcinoma, or I'm not sure what to say. There is no correct answer because these are rows images, and we thought many things at the time. So what would you say? What do you think?
There are some answers being typed into the chat box, but I think we'll wait for the poll to end and then see what the answers are.
I'll give 15 more seconds or so, Ash.
Can you think of a good joke to tell in the meantime, Christian?
I have absolutely no jokes here. I'm being very professional, Ash.
We all are very professional.
We can have fun without telling jokes, right?
Sometimes.
Okay.
Well, let's see. Okay, I like that answer. 53% of them thought there were germinal centers. 36% granulomas, none of them carcinoma, and 11% of the participants were not sure what to say. And I really like these answers. Oh, sorry. This This is the sample obtained. We decided to perform a biopsy, of course. The pattern surprised us and looked like an interfollicular histiocytic-like expansion with small follicles intermingled. So we did a broad IHC panel which showed a reactive follicular pattern. However, the key 67 was very high in a few cells. So we performed keratins and this is what we got. So we went back to cytology and we found this foci of cell groups and looked more closely. This fooled us too. We were not sure about the findings at Rose, and this is what happens. Neither Rose nor we are infallible. It's not the same to see Rose as it is to see the final slide on your table. And given the doubt and the clinical features, we decided to perform that biopsy. There were no data of primary neoplasia on imaging in a CT scan. And there was high clinical suspicion from ENT for neoplasia. So looking closely, we saw these cellular groups, atypical cell groups, and they corresponded to a lymphoepithelial neoplasm, most likely from Kabum. In this case, as I said, we avoided a diagnostic cervicotomy because we were having a hard time with the third wave of COVID, and there were limited surgical shifts. I brought this case because the combined approach also gives us this wider view. It fooled us too. We thought about germinal centers, and when we saw the core, we were surprised because they were mostly atrophic. So let's have case 3. This is a dramatic and also a great case. This is a 28-year-old woman in follow-up for 5 years because she had bilateral otalgia and left otorrhea with no improvement, with several treatments, as well as frequent fungal infections. In physical examination, she had a narrow left external auditory canal with conspicuous edema without palpable tumor, but with a lot of pain at the touch of the area. The patient was referred to the FNA consult, and the ultrasound showed us this lesion with irregular contour and measuring almost 3 centimeters and independent of the parotid gland related to the ear tragus. This was a preauricular scan right here. So this was the pattern we had. The FNA showed an atypical epithelial cell proliferation with cylindromatous pattern, like cystic adenoid carcinoma, sorry. And the patient reported a very intense pain during the procedure. This pain has been reported as an associated symptom due to frequent perineural invasion. And another image here. We are thinking about something right now, don't we? So let's do some polling. And given this cytological pattern, what would be your diagnosis? Malignant salivary gland tumor, an adenoid cystic carcinoma, just malignant tumor, or I think this lesion comes from the ear and not from the parotid gland. Remember, we are scanning here. This is another advantage. You actually are seeing where the scanning is being done. So what do you think?
While we wait for the polls to launch, Karen, I was just going to ask you, how do patients, respond to having, ultrasound-guided FNAs, core biopsies, and do you actually discuss the results with the patients while you've got them there with you?
This is a nice question, because it depends on you, as always. If you are not comfortable discussing the results or the findings with the patient, then don't do it. If you are comfortable and are pretty much sure about what you are seeing, and you are going to give, let's say, a beautiful weekend to a woman who has a benign lesion in breast, well, you can do it. You can tell her, I don't think this is a malignant lesion, so please go home and take a break and have a nice weekend. And adenoid cystic carcinoma.
And I think the results are back.
Okay, I'm loving this answer, because this was a quite difficult case. Given the cytological pattern, 12% of the participants think this is a malignant salivary gland tumor. 75% of the participants think this is an adenoid cystic carcinoma. 12% just a malignant tumor, which is okay. And 1%, I think this comes from the ear and not from the parotid gland. This is a quite challenging lesion. Now, let's say we, of course, decided to perform a biopsy of the lesion. The needle image below the arrow on the left is the needle. And we were able to obtain only one core because of the intense pain the patient showed during the procedure, despite adequate local anesthesia. This is the imprint rows from the core needle. And we knew we had a sufficient sample, because when you have just one shot, it may be a better one. So these were the findings. The biopsy showed extensively infiltrated tissue by a malignant neoplasm with a mixed tubular and focally cribiform pattern with intense desmoplastic stromal reaction, and here at higher magnification. Now, returning to the ultrasound image, the hyperechogenic line at the bottom is remarkable. And what we are seeing here, we are seeing the patient, and we know which part are we scanning and where we are scanning. We know where the probe is placed, and we know that according to that, this corresponds to the tragus of the ear. Simple, a macro on screen, real time. And it correlates with cytology in a spectacular way. We leave you this image of cartilage infiltration. I had to move the micrometric focus, because here you have the neoplastic component infiltrating the cartilage. And this image is for that 1% who answered that this comes from the ear. And now, this is the key slide. With all the information we have after an exhaustive examination, we saw preserved apocrine-type glandular structures with eosinophilic cytoplasm and yellowish brown gold cytoplasmic granules. And they were intermixed with the neoplastic lesion. The diagnosis we made was adenoid cystic carcinoma type malignant neoplasm with origin in ceruminous glands of the external ear. During the examination, we scanned the parotid region and found just an intraparotid lymph node. This is a normal appearance, a common finding in parotid with normal ultrasound pattern in the gland, as we have already seen. Otherwise, this is normal for a parotid gland. and this was the CT scan. We can see significant narrowing of the auditory canal and the soft tissue tumor. And even if we don't know anything about CT scan, we can compare to the technically normal side and we can see the lesion. Can we? We can see the lesion. So this is how POCUS works. The pathology is seen, and if you don't see it clearly, you simply compare it with the normal side, and that's it. Even with this C-kit, CD117, the key for diagnosis is this dual population of glands and the location of the lesion by imaging studies outside the parotid gland. This is a nice image to remember. Well, for case number 4, we have a 46-year-old patient with pathological lymph nodes at right cervical level 3, it's here, right here, and also several lymphadenopathies in right cervical 2 and 4 level, bigger than 1 centimeter in left jugular chain, very suspicious of malignancy. This is an awesome case. We observed a malignancy and thyroid origin features on the rows. This was the image. This was one of our very first cases. We saw this nodule in the neck and we sampled it and we obtained this. We saw nuclear inclusions, swirling, and many follicular cells. Here in more detail, and this reminded us to thyroid gland. So now let's do some polling just for fun, remember. Now, in consideration of the features at rows, what would be your diagnosis? Bethesda 4? I mean 6. I tell my colleague to perform a neck ultrasound and wait to sign the report. I say malignant and that's it. Or I perform POCUS of the thyroid and see if I can find a nodule to sample and match with the findings. This is a catchy one.
That's great. So while again we're waiting for the polls, just for a bit of chat, Karen, are your patients all booked previously, with an appointment, or are these walk-ins from a clinic in the hospital?
Mainly they walk directly to our consult from their treatment physician office. Not always they have a previous appointment, but you can do it that way if you prefer.
I see. So do you have a system whereby you have, you can offer as well as take walk-in appointments as well?
Yeah. Usually it's walk-in appointments, but we can also do previous appointment system.
And you, give the clinician a ring with the results? Okay, maybe
with the rows findings, yes. When we can, if we see clearly malignant or clearly benign, we call them. And also, if we are not quite sure, we tell them, hey, I'm not sure what I'm seeing here. I perform biopsy or not, and let's wait for all the sample obtained, and they understand.
Lovely, thanks. So you've got the results of the poll there now.
Well, 73% of the participants said perform POCUS of the thyroid and see if I can find a nodule to sample and match with the findings. 18% have a Bethesda 6 diagnosis. No one says to wait to sign the report until the neck ultrasound is done. And 9% said it's malignant and that's it, and that's okay. Well, there's the pap smear in case of any doubt of the findings. And we decided, of course, to scan the thyroid gland and look what we found. An heterogeneous nodule on the thyroid isthmus with peripheral vascular enhancement and calcifications. What do you say? Should we sample it? And of course we did. Having an ultrasound and performing rows allowed us to find the primary lesion. And look what we found, highly atypical cell groups with cytoplasmic vacuoles, pycnotic irregular nuclei, and there was similar features in the lymph node and the thyroid. During the same visit, we found with focus and rows the primary tumor, and the final diagnosis was carcinoma metastasis in the lymph node, indicative of thyroid primary origin, and in the thyroid, a papillary thyroid neoplasia at Bethesda 6. And the surgical specimen had multifocal papillary carcinoma infiltrating the peripheral thyroid tissue with multiple lymph node metastases.
Karen, could I just, before we go on to case number 5, there's a couple of questions from the audience. Do you use local anesthetic before you perform an FNA?
FNA, well, sometimes. And this is what we were saying during the presentation. It's up to you. It's up to the patient. If you will be more comfortable because the patient is going to be more comfortable too, and will have not any pain and will be more relaxed, and you will be more relaxed too, you can put local anesthesia without any problem. We use mepivacaine and epinephrine. It's a previously mixed combination, but you can use only mepivacaine without any problem.
Lovely, thanks. And one question coming from a colleague who I think missed out on the diagnosis of the ear lesion. I think the ceruminous gland carcinoma, was that what you'd said?
Yes, yes, ceruminal gland carcinoma, yes.
Yeah, so yeah, rare entity, but you know, that was a great case. Okay, I think we're ready for case number 5 now.
Case number 5 is a male, 76 years, former smoker, with right pleural effusion, with bilateral cervical lymphadenopathies, bigger than 1 centimeter, with this pattern on ultrasound, and you now can recognize pathological pattern of a lymph node in the ultrasound. We had 2 major problems in this case. And even if the lesion is palpable, we do not know if it's close to vascular structures. So again, we see the importance of ultrasound guidance. The major problems in this case were the patient's breathing movements. These were actually the patient's breathing movements. And the other problem was the location of the lymph nodes, pretty close to the vessels. So the advantage of being able to scan other areas with ultrasound, it's this. We found another nodule, a larger supraclavicular soft tissue nodule in the supraclavicular area. This is focus, fast and non-diagnostic scanning for decision making. And by the way, again, no one is going to tell me this is a normal ultrasound pattern. This is absolutely pathological with irregular margins, you can see here. An heterogeneous pattern with these images suggesting necrotic tissue, but you are not going to put this in your report. You have this in your mind to correlate with your cytological features. And this is what we found, an atypical cellular proliferation that was arranged in clusters of variable size with a not too dirty background and this cytoplasmic vacuoles. So let's do some polling just for fun. Given these findings, this lesion is malignant, and that's it. It's malignant and a biopsy is recommended, or let's make a diagnosis with a cell block. I'm not sure what to say. Let's wait for the biopsy and imaging to sign the report. What do you think?
Okay, so again, while we wait for the answers to come back, Karen, do you have sort of a set protocol as to how many slides you make from each pass? You know, once you've collected a sample, you presumably just hand the needle over to your PA or BMS or cytotechnologist. And is there a set protocol that you follow then?
We have not a protocol. We have not a protocol for the number of slides. And again, this is according to what you need. If you have just one slide and you see it's enough for making a diagnosis, just one slide can be diagnostic. And you don't need, I don't know, 10 slides. It's depending on the lesion, on what you want to see after that,
Absolutely.
and depending on rows, because if you don't have any material or any sample at all in rows, well, you will certainly do another pass and have more slides.
Lovely.
Okay, I like this answer. I like this answer. So given these findings at rows, 1% of the participants thought this is a malignant lesion and that's it. 46% thought this is a malignant lesion and a biopsy is recommended. And 54% said, let's make a diagnosis with a cell block. And none of them will wait for the biopsy and imaging reports. I like this question and the answers, because there is no correct answer. This is only a proposition, I don't know, of having cell block 2.0 to perform this kind of diagnosis. This is the pap smear with more detail, suggesting so far a carcinoma, maybe more likely an adenocarcinoma. And after rows, of course, we decided to make a biopsy. Another thing that I would like to point out is no one would think this is a good or benign lesion. So it's something intuitive, as we said, the irregular contour, and this is point of care. In this case, breathing movements were constantly causing the procedure to be more difficult. This was not me, this was the patient breathing. The ultrasound guide allows a complete visualization of the needle path and avoid surrounding structures like this fellow right here. So we conducted a selective sampling of different areas of the lesion. In red, the previous path, and in green, the actual path of biopsy, the current path. These are more advantages. We can obtain samples from wherever we consider appropriate, from different areas of the lesion, in order to obtain a wider picture. And this was our biopsy, with perfect correlation with cytology. We had also positivity for TTF1 and NAPSIN-A, and the diagnosis of metastatic pulmonary adenocarcinoma was made. Even NAPSIN was beautiful in this case. So a good amount of tissue is needed for multiple biomarkers and molecular tests. We are constantly being asked for more and more and more, with less and less and less. So let's maybe try to get more tissue by ourselves, if possible, in order to work more at ease. What do you say about this? I would love to have a polling right now, but I don't have it. So Thank you very much for your time, for your kind attention, for being here with us and staying online with us. Again, thanks to all of our team, because none of this could be happening without them. And once again, this is our contact information. We are always at reach in our official channels and social media.
Fantastic. Karen, what we miss at these meetings is the sort of the thunderous applause that you would get at the end of such a presentation. So but I'm afraid you'll just have to imagine it as virtual applause with, you know, more than...
It's better that way, because I don't know, I would be embarrassed.
No, not at all. You shouldn't be. It's been absolutely brilliant. And all the compliments are coming in now. Instead of questions, now it's all, you know, thank yous and wonderful. But there are a couple of questions and comments, actually. One that is asking, do you prefer core biopsy over a cell block?
Actually, yes. If I can have core needle, I prefer core needle. And I can have a cell block, a good cell block too, because even if I don't make it, my PA, let's call her that way because it's shorter, my PA is able to make an awesome cell block. But if I have the possibility of making a core needle, I actually do core needle. If I unfortunately don't have the possibility of having a core needle, of course, I make the diagnosis on cell block.
Fantastic, thank you. Just a comment coming in from a colleague, just saying that diagnosis can be made on cell block material and NGS is possible using molecular tests. So yes, thank you.
Yes.
Yeah.
This is a possibility, as I said, a convenience store.
Absolutely. Another comment coming in about any inadequate samples with POCUS or ROSE and any post-procedure morbidity, hematoma. Do you encounter any complications?
The frequent complications are maybe local pain, hematoma, depending on the tissue, breast, maybe. But so far, we haven't had any serious complication, just local pain and maybe hematoma.
Yeah, sure.
Nothing more.
Yeah, and I'm sure, you know, obviously the number of inadequate samples would have been...
inadequate samples. So far, I think there are almost none, because we perform core needle in cases, in selected cases. You are not going to perform core needle in a 2 millimeter lesion, because that's the radiologist's work with another kind of devices. We use mainly simple core needle devices, and also bigger lesions for core needle, at least 1 centimeter. So with the power of FNA and ROSE before core needle, you will not have almost none insufficient sample at core needle.
Absolutely. Thank you. There's a whole sort of string of compliments coming in. We'll download these for you, and so you can sort of read them later. Karen.
Thank you, everyone. Thank you, everyone. Really, I really appreciate it.
They've all enjoyed the cases. They've enjoyed the polling. And in fact, we have a non-Spanish speaking colleague saying, muchas gracias, mucho gusto.
Muchas gracias a todos por estar aquí. Thank you very much to everyone. And again, thank you to the BAC for this invitation and the opportunity for me and my colleagues to be in here, even online. It's great to be here. Thank you. Thank you very much.
Well, thank
and
you.
All the participants, of course, for their patience and being online all this time.
They've all been marvelous. And thank you for finishing, you know, bang on time, as it were, with a couple of minutes to spare. I think what we might do is take a short break now, maybe just a 10-minute break, if that's all right. Come back at, you know, 10 minutes time so that we can start warming up to the next session. You know, get yourself a cup of tea or coffee or drink of water, whatever. But Karen, thank you very much for taking us through an area which obviously, expansion of roles of the pathologist or the cytopathologist into the territory, classically regarded to be that of the radiologists, but obviously a shared territory, as you seem to have, shown to us today. So thank you very much for your time. We're so pleased that it finally happened. Next time, perhaps with a practical hands-on session, wherever in the world we next meet. So
let's hope.
Okay, thank you. So we'll take a little break and we'll be back in about 10 minutes for the next session. Thank you all very much.
Thank you, everyone.
Thanks, Karen. So again, thanks everyone for staying with us, and I'd like to introduce Dr. Tony Maddox and Leonie Glinsky, who are going to present the next session. And as anyone who's been on has heard, there's also going to be a video presentation within this session as well. And then we'll have a Q&A discussion forum at the end. So I'll hand over to Dr. Tony Maddox now. Thank you.
Great. Well, thank you very much, Alison. So let's get right on with it. So the objectives for this talk, and also kind of the running order, is that I'm going to discuss some of the background and guidelines and evidence to do with head and neck FNA, and specifically to do with rapid on-site evaluation. And then the thing that's not on the slide is that there will be a video, which will be a 14 or 15-minute video, which was actually shown as part of the webinar that came from Cornwall just a couple of months ago. But it's a beautiful presentation of a head and neck FNA with a diagnosis involving rows, and there's some lovely radiology and cytology to look at there. So that's going to be in the middle. And then after that, my colleague Leonie Glinsky, Senior Biomedical Scientist at Royal Cornwall's Hospital NHS Trust, will talk about some recent audits and surveys into this area, discuss some possible future directions, and then hopefully a discussion at the end. So I'm just going to say rapid on-site evaluation in the head and neck. Essentially what it allows you to do is manage the specimen and therefore manage the quality of the preparations, and also gives the opportunity to perform triage. So in other words, if you know that you're based on rows going to need immunocytochemistry or molecular analysis, as is increasingly going to be happening in thyroid, microbiology in the case of purulent or granulomatous material, or flow cytometry if you're interested in particularly low-grade lymphoma, then it allows you to do that at the time of the procedure. It also gives immediate feedback to the aspirator, whoever that might be, as to whether the site is yielding diagnostic information or not. And this is a kind of a soft thing, but nonetheless valuable. It gives you an insight, and anybody who's present in the room, into the patient experience, and makes you realise that actually it's very easy when you sit at your microscope to say, well, this specimen's rubbish, we just need another one. But it gives you an insight into what that means and what patients have to go through in order to get these specimens. So that's actually a very useful thing, a clinical interface. What variables are there? Well, all of these things. So the aspirator might be a pathologist, as we've seen already, frequently a radiologist, or could indeed still be somebody else. Surgeons, there are still some surgeons doing freehand FNAs, probably. It may be done by ultrasound or not. Increasingly it is. The evaluator, the rows person, might be a pathologist, or it might be a biomedical scientist or cytotechnologist. And the method, and when you're reading papers about this, sometimes the methods are a little sketchy, and they often don't tell you actually how many people are doing rows, whether there's one BMS, two BMSs, or a pathologist and a BMS, or what, and also what the stains are. They sometimes specify them, sometimes don't. So it's worth just keeping that in mind as you're reading these papers. And also, crucially, what training of the people had that are doing rows. And again, sometimes the papers don't say that, particularly if it's a BMS or a pathologist. So just to talk through some guidelines really quickly, way back in 2004 in the UK, National Institute for Clinical Excellence, or NICE, produced this document, Improving Outcomes in Head and Neck Cancer, and they suggested that we should be setting up rapid access neck lump clinics with on-site cytological expertise, and they actually costed it. Assuming a BMS present in a once-a-week clinic, it was £2.2 million per annum. And then in 2009, the BSCC, is one of the parents of the BAC, the British Society of Clinical Cytology, produced this document. This is the Code of Practice for FNA, and again suggested that you could have on-site adequacy performed by experienced biomedical scientists under the guidance of cytopathologists. And it said that the facilities should be there for making and staining the slides, doing ancillary tests, and assessing adequacy. And more recently, this is the Tissue Pathways for Diagnostic Cytopathology, came out from the RC Path nearly 2 years ago now, and said that the most cost-efficient method of providing this sort of thing with no compromised quality is to have trained BMSs providing on-site assistance. This is an American guideline, as you can see in the top right. It came out, I think, in 2017, and essentially what it says is, first of all, it says that neck lumps should absolutely be examined by fine needle aspiration and not by open or excision biopsy. And it mentions that on-site evaluation by a cytopathologist assessor can reduce the inadequacy rate. And also it talks specifically about you may need to flex to a core biopsy, particularly if you're interested in lymphoma. And we've already seen that you might flex to a core biopsy for all sorts of reasons as well. But having assessment at the time allows you to do that. So those are some guidelines. What about some recent papers? So I'll just go through 2 or 3 recent papers before I have the video. So this was a review last year in Cytopathology, David Poller, and also some co-workers from Switzerland who used the RC Path Thigh terminology. And they looked at rates of Phi-1, so non-diagnostic FNAs, and compared papers describing rows together with papers where rows wasn't available. And they used the 25 papers in the study, but they looked at 23 specifically for the rows, non-rows thing. And the bottom line is there are about nearly 6,000 aspirates in the papers that use rows, and about just over 11,000 in the papers that didn't use rows when you added them all up. And papers that did use rows, 6% showed an inadequate, Phi-1 rate was 6%. And in the papers that didn't use rows, the Phi-1 rate was 18.5%. And those are just the 6 papers that describe rows. And you can see on the right-hand side, there's split between biomedical scientists and pathologists, but fair numbers. And we'll look at the paper by Sharma, which is the 3rd one down, just in a couple of minutes. But they do say that rows isn't essential, and it's a meta-analysis quoting another meta-analysis, but Witt and Schmidt, a great name for a music hall act, but Witt and Schmidt in thyroid showed that rows does improve the inadequate rate from 17% to 8%, but that's most marked where the inadequate rate is already poor, and that's kind of what you would expect. Clearly, if your inadequate rate is already 5% or something, you're not going to be able to improve very much almost whatever you do. And they do say that the 3 British centres, one of which is a very high volume centre, who don't have rows also do have very low inadequate rates. And they make the point that really what you're going to need without rows is certainly good ultrasound, excellent support with good communication with cytopathology, and probably high volumes. And this is a good general point. So what they're saying is, if there is very good communication and very good engagement between cytopathology and whoever is doing the aspirate, whether that be radiology or endocrinology or surgeon or whatever, then that's going to produce better results. So it's a key point that good clinical engagement from all sides produces better results. What ROSE does is it kind of drives that. It forces you to have engagement because you're actually there, but it's not, you know, you can clearly produce good results if you do have that engagement, even if you don't have ROSE. This is an American review, and again, it's another meta-analysis, and they quote a number of other papers just briefly. So Pastorella was actually a Brazilian paper, and again showed a very good inadequate rate, 6% with ROSE and just over 30% without. Zhu was an American paper with almost very similar figures. Olson was actually the John Hopkins Baltimore people, and they showed that the inadequate rate when BMSs did ROSE as opposed to pathologists doing ROSE was almost identical. And I think after that paper, they pretty much stopped pathologists doing ROSE, and now they have a team, I think, of 8 cytotechnologists or BMSs who do the ROSE for them. and get very good results still. But, and it's important to point this out, so this is a paper, O'Malley, from somewhat earlier, and not a huge number of cases, but it does show poor results both with and without rows, and the procedure is lengthened massively from 13 to 44 minutes. But I would have to say, having read that paper just this morning, I finally got a copy of it, they did rows on all of the slides from the aspirate, so sometimes pathologists were looking at upwards of 12 slides from the past. So I think that may explain why the time period went up. The other point they make is that rows does provide essential feedback in training, an opportunity to change what you're doing at the time of the procedure. That's kind of the whole point, an opportunity for triage. And they a quote from the paper says it's essentially going to become essential, possibly with molecular testing. This is the paper I refer to, again, in this American journal, the American, and the author is the American Academy of Otolaryngology, but actually the paper is from Romford, Essex, so, so much closer to home for me. And this is quite interesting. So they looked at 4 groups, and what they did is they took specialist radiologists who had an interest in head and neck FNA, and gave group 1 on-site cytology. Then they took general radiologists who didn't have a specific interest in head and neck FNA, and they didn't have on-site cytology. So you've kind of got opposite ends of the spectrum there. But then they took a particular specialist radiologist, a single radiologist who was not in group 1, and gave them on-site cytology. And then they had the same specialist radiologist without on-site cytology. Those are just the numbers, and if you add all those up, they come to just shy of 400. There's about 400 FNAs in the whole study, and it lasted about a year. Thyroids were the largest, but they had also carotids, lymph nodes, and some soft tissue as well. And this is what it shows. So group 1, remember, group 1 is specialist radiologists with rows, the inadequate rate 13%. Group 2, general radiologists without rows, inadequate rate of 44%. So a very significant difference. And then group 3, a single specialist radiologist with rows, 10%, and then without, unfortunately, I can't actually see if I move that. Yeah, 22%. Sorry, I've got a window in the way. So again, a significant difference, and that was a well-controlled comparison, those two. Finally, lymphoma. So just one paper about lymphoma, and this is a paper from Australia a couple of years ago in Cytopathology again, but they looked at the combination of cytology FNA and flow cytometry. So 1,400 cases over 5 years, roughly, all of them, virtually all of them ultrasound guided, roughly half and half with and without rows, and the rows is by biomedical scientists or cytotechnologists. And if they saw an aspirate which was purely lymphoid, they always did a pass for flow cytometry. Without rows, they always did a pass for flow cytometry because they didn't know what they had. And of those, so there were about 80% were negative, and this is combining cytology and flow. So about 80% negative, 5% atypical or indeterminate, about 12% suspicious or malignant, 11% were insufficient for flow, and then there were 11 cases which where the cytology and flow was insufficient. So excluding those 11, you end up with these numbers in the bottom. So after correlation follow-up, which means any histology that was done, radiological follow-up, and all those sort of things, and surgery, if there was surgery or excision biopsy, whatever happened, and that follow-up, I think, was 6 months, or it might have been a year, they came to this conclusion that just shy of 1,200 were true negatives, 199 true positives, and there were a number of false negatives and false positives. But what that means is, look at the table on the right, non-Hodgkin lymphoma and Hodgkin's. So Hodgkin's doesn't do very well, you'll see in the next slide, but if you include Hodgkin's, even then, specificity, PPV, and MPV are all over 98%. If you take Hodgkin's out, they're all over 99%. And this just shows that. So these are, if you look at the histogram on the right, so these are all the cases of lymphoma which were diagnosed. So particularly if you look, let's say if you look at CLL, small lymphocytic lymphoma, the small orange band at the bottom is about 5% were indeterminate. All the rest had a positive diagnosis made by flow plus cytology. Diffuse large B cell, which is the next one, about just over 10% were false negatives. So that's what the blue is. And then the orange were indeterminate. So you can see the more gray there is, the better. And essentially for small lymphocytic lymphoma, follicular lymphoma, mantle cell, marginal zone, and plasmacytoma, of which there was only one case, actually it did very well. Where it didn't do so well was Hodgkin's is clearly pretty poor. There are only 13 cases, but there are quite a number of false negatives. And diffuse large B-cell, where the false negatives were actually, it seemed to be poor sampling. But for low and intermediate grade lymphomas, it looks like it does a combination of flow and cytology gives you very good results. And just to move, I'm sorry, I'm having to move windows around to see. But the ones that were insufficient for flow, interestingly, there was a significant difference between whether you had rows or whether you didn't, even though essentially it was a single pass put into medium for flow. Actually, having rows did improve flow cytometry, and sensitivity improved, as did NPV. So after that brief scamper through that, there's reasonably good evidence that rows does improve outcome in both thyroid and indeed other head and neck aspirates, and also in lymphoma, as we've seen from that last paper. But there are major issues. You know, you need people and the time to provide those people. That costs money, and also you need training. And we'll discuss that a little bit later on. So I'm now going to bear with me a bit while I run this video. So this is a video, you can see the people there, they will introduce themselves. This is a video from the Royal Cornwall. It's about 14 minutes. It's an excellent case with beautiful pictures. So I'll just run that
now. Good afternoon, everyone. Thank you very much, Leonie, for inviting us to speak at this British Association of Cytopathology webinar. We are Dr. Tim Bracey, myself, consultant pathologist. We've got Venkat Reddy, consultant ENT surgeon, and Dr. Ben Rock, who's the consultant radiologist. And we're going to present a case of a neck lump from the context of our virtual neck lump clinic.
So this was a patient that presented to the ENT suspected cancer clinic, where we have ultrasound scan by radiologist or radiographer and a cytotechnician to assess the adequacy of the specimen. The patient had a 3-month history of a right-sided neck lump with also progressive pain in the right cheek and right ear, which was getting worse when they were chewing. So in keeping with our usual management guidelines for neck lumps, following a clinical assessment, an ultrasound scan of the neck with fine needle aspiration for cytology was performed in clinic by a radiologist with rapid on-site evaluation.
So this is the ultrasound that we performed in clinic. Ultrasound can look a bit like a snowstorm to the uninitiated, but I'll try and take you through it. So this area here is the normal looking right parotid, and it normally has this kind of slightly bright appearance. This is the mandible here, and this is the masseter muscle overlying the mandible. And then if we just look superficial to the masseter muscle, we start to see this hypoechoic area, which is the lump that the patient was feeling. So here we go, it's within the superficial part of the parotid gland. This is the superficial part of the parotid gland curving over the masseter muscle, and there's this hypoechoic area, which is just bulging superficially from the parotid capsule. As we move a bit further forwards, we can just see the edge of the lesion here. Here's the masseter muscle. The ducts would normally run over the masseter muscle here. If we just scoot on a couple of pictures, we can see that the lesion is extending quite far anteriorly over the masseter muscle. It looks a little bit irregular. So these appearances are really quite non-specific. You could see this, for example, with an inflammatory process. Inflammatory processes can look quite irregular and ill-defined. It also could, at this point, represent a neoplasm. So really, FNA would be essential here to kind of triage and guide further management. So our normal practice would be to go on and perform an ultrasound-guided fine needle aspiration, and we're very fortunate to have the facility to do rapid on-site evaluation. So we get an instant result as to whether we've got adequate material. If not, we do have the option of performing a cord biopsy, but that's not without risks within the parotid gland. So FNA is a great first-line test.
Okay, this is extremely low power view of a diff-quick stain of the very cellular FNA, and at this low power you can't really make out any cytological detail, but you can appreciate that there are stromal material and a lot of dark blue cells that are lining those stromal clumps. And then at higher power, you can appreciate that stromal material is sometimes made up of rounded and tubular clusters of this quite deep magenta purple staining material. And then it's coated with these very dark cells that are only slightly bigger in that view than red blood cells that are scattered around. And then this is a slightly higher power view showing that these stromal clumps of magenta material, extremely well demarcated edges to them, quite crisp edges, almost cut out with a sort of cookie cutter appearance. And then there are these round to oval, quite dark staining tumor cells surrounding, which have very little cytoplasm at all. There's no necrosis or obvious mitotic activity.
This is the MRI scan that we performed. We'll run through a couple of sequences here, and I'll just try and explain to you what we're looking at. So this is a T1 weighted axial sequence, and as we come up through the neck, we'll eventually get to the parotid glands. T1 is a really great sequence for trying to identify the extent of pathology, particularly within the parotid glands, because the parotid glands tend to get infiltrated with fat, so you see pathology nicely outlined against the fat. So this is the lump that we were seeing on the ultrasound appearing as this dark mass against the bright parotid gland here. Here's the normal parotid gland on the left-hand side. So we can see the lesion overlying the masseter muscle and the ramus of the mandible here. This is actually the retromandibular vein, and the facial nerve will be running in a plane roughly along here. We can just see the facial nerve actually coming out of the salivary foramen there. So the lesion is extending towards the facial nerve at its deep aspect. So that gives us some idea about the lesion extent. We want to try and characterize this a bit better now, so we can do various different sequences. T2 weighted sequences can be useful in characterizing parotid lesions. In general, benign lesions tend to be very bright on T2 weighted sequences. The story that we're told as radiologists is that they tend to be quite watery lesions, and darker lesions tend to be more cellular. So we tend to get a little bit twitchy if we see darker lesions on the T2 weighted sequence, and this is quite dark. This is CSF here, so that's fluid signal, and this is darker than fluid signal. So there are some worrying features on that T2 weighted sequence. We also like particularly for salivary gland pathology, and that's because contrast can more accurately delineate the extent of particularly tumours, and particularly in the context of perineural spread. So if we have a look at the mass on this fat suppressed contrast enhanced sequence, we suppress the fat because otherwise the fat is bright and the enhancement's bright. So we get rid of the fat signal, and then we're left with the white signal of the tumour. We can see the tumour here, and there's this little strand of enhancement which is extending anteriorly over the masseter muscle here. We'll come back to that in a second. And there's also this strand of enhancement which is extending around the posterior aspect of the ramus of the mandible, and you can follow it around here, and it's actually splitting around this this dark structure here. And this is actually the middle meningeal artery, and the structure that takes that course and splits around the middle meningeal artery is actually the auricular temporal nerve, a branch of the mandibular division of the trigeminal. So this process is following the expected path of the auricular temporal nerve. If we have a look on the coronal sequences, again, we get really nice volumetric coronal sequences on this contrast enhanced sequence. It lets us sort of map the extent of enhancement really nicely. We can see the strand of enhancement extending over the right masseter muscle, and this is actually following the expected course of the buccal branch of the facial nerve. So the facial nerve divides into 5 branches, the pes anserinus, and it's extending here along the buccal branch of the facial nerve. As we come back, we can follow that strand of enhancement that we saw before. This is the foramen ovale. So there's enhancement extending up the main trunk of the mandibular division of the trigeminal nerve towards the foramen ovale. So on the basis of this MRI, it really looks like there is evidence of perineural spread of the pathology. So now, really, we're into the realm of malignant pathologies. So I would be worried here that this is a malignant salivary gland tumor. The things that we see do this on imaging. Various tumors will do it. So, for example, squamous cell carcinoma is the commonest tumor that we see doing it within the head and neck. Melanoma can do it, lymphoma can do it, but particularly in the context of salivary glands, the tumor that is renowned for doing this is adenoid cystic carcinoma. So radiologically, at the moment, my differential would be of a malignant tumor within the salivary gland with possible histological diagnoses that I've just mentioned.
On the left, there's the stromal material that you get with pleomorphic adenoma, which accompanies the tumor cells. So in that way, there is a bit of a crossover. You get, with cytology, FNA, you get a mixed stromal and tumor cell pattern in both tumors. But the stroma is much more, we sometimes talk about textures with visual things, which is an odd thing to say, but the stroma is much more wispy and almost like candy floss. Although it is the same color as the adenoid cystic carcinoma, stroma is much more fibrillary, metachromatic stroma. And the tumor cells are often mixed in with that stroma rather than congregated on the outside of the stroma like you get with adenoid cystic. The tumor cells are often quite squashed and difficult to see within that stroma. But even when the stroma is scanty, which is quite often the case with pleomorphic adenoma, it can be epithelial rich rather than stromal rich. And on the right panel, these sort of more plasmacytoid cells where there's much more cytoplasm and the cytoplasm is eccentric. And then you get occasional large anisonucleotic cells within pleomorphic adenoma, which is not a worrying feature. And in fact, those plasmacytoid cells with the metachromatic stroma is virtually diagnostic of pleomorphic adenoma. Just to superimpose the sort of classic features of adenoid cystic carcinoma, you can see that metachromatic stroma is much harder edged and much more separate from the tumor cells.
So the outcome of the discussion from our head and neck multidisciplinary team meeting was that we should pursue surgery in the first instance. There's an understanding that obviously with regards to the extent of the disease, that you're not going to get macroscopic clearance. And obviously the nature of adenoid cystic carcinoma is such that even if you have got macroscopic clearance, you're likely to have skip lesions within the nerves. But the plan for this patient was to offer a radical parotidectomy with a neck dissection. And we expected that it would be likely that the facial nerve would be affected, and therefore a plan for primary facial reanimation was made to minimize the impact of facial nerve palsy, and a plan was made for post-operative radiotherapy as well. And I think it's really important just to kind of like appreciate, whilst Tim was saying that it's difficult sometimes to be able to differentiate between the different pathologies, the approach for, say, a pleomorphic adenoma would have been significantly less than we're proposing for an adenoid cystic carcinoma. The implications from the patient's point of view in terms of the complications of surgery and the risks of facial nerve injury and facial nerve excision because it's involved in disease, that's something that you would only countenance in the context of adenoid cystic carcinoma probably, rather than a benign pathology such as pleomorphic adenoma. So it's important to appreciate that there's quite a significant difference in terms of the implications for the patient from the treatment plan that we would propose. So it's worth being aware, we've said that it is likely to have skip lesions. The prognosis is uncertain from the outset. It's usually quite a slow disease, and late recurrences up to 20 years are reported in the literature, possibly beyond that as well. It's just that the literature doesn't tend to go beyond that. And there are trials for which patients might be eligible if there's evidence of radiological progression of the size of remnant disease. And so therefore it's important to continue to monitor these patients. And obviously in regard of where this disease is, it's not something that's necessarily going to be evident from clinical examination. So surveillance relies heavily on radiological appearances. So I think it's worth pointing out the value of the neck lump clinic in the context of this particular case. We're fortunate to have access to same-day ultrasound scan with a radiologist or radiographer that's an expert and specialist in head and neck ultrasound, and also that we have the availability of rapid on-site evaluation, because this significantly does minimize the delay in diagnostic workup. We know if we've got a cellular sample right from the outset, and if we don't have a diagnosis from that, we know that it's not going to help to repeat that in terms of fine needle aspiration. But also, if we have an index of suspicion that there is cancer, particularly in the context of a corrosive pathology, we could potentially go on to do a core biopsy at the time, which further reduces the diagnostic pathway. It's almost like we have a small multidisciplinary team discussion there and then when the patient's actually assessed in clinic, which then guides us as to the appropriate course of investigations, which means that often we're able to anticipate whether it's an MRI scan or a CT scan or what type of investigations we need to request based on that discussion at the time, which obviously reduces the delay in actually finding out what those first-line investigations are and what further investigations we need to perform thereafter. In the context of this particular case, an inflammatory condition could have presented in a similar manner, but because we were able to have that mini MDT discussion within clinic, because we have this multidisciplinary neck lump clinic, we're able to reduce the overall delays in terms of getting to a point where we have a definitive management plan for the patient.
Okay. So let me just go back to the presentation. Actually, for any trainee pathologists among you, just notice how easily the radiologists move from ultrasound to MRI to CT to back again, and that's really the facility you need to have with histopathology and cytopathology. I just say that by the by. Right, so if I move back to this presentation, move back to
Ash, there's and Anthony, there's a couple of questions there. I don't know if you want to address them now or later.
Now then, because I'm sharing my screen, I'm not entirely clear.
Okay.
I can read them out to you if you wish. There's 2 or 3 cases and questions there. So there's a question about, would radiotherapy not be tried first to shrink the lesion and monitor before neck dissection? I suppose this is really one for the radiologists who are only here virtually. So Tony, do you want to?
I'm not sure I could answer that in any meaningful way, unless Leonie has any better knowledge than.
I'd rely on the MDT for that decision, I think.
Yeah, absolutely. I think those are the kind of decisions which are helped by having the a provisional tissue diagnosis, a cytological diagnosis, at the MDT or in the clinic, because you can actually make a decision about whether a patient should be offered neoadjuvant treatment, such as radiotherapy or chemotherapy, based on the cytological evaluation. So I think the short answer to that would be yes, it could be tried, but it depends very much on what tumor we're talking about, and what stage we're talking about, what levels of neck dissections we're talking about. So in general, yes, but obviously very, very patient specific. Another question here, would you consider doing MIB fusion molecular tests in ambiguous cases of adenoid cystic carcinoma?
Well, yeah, I mean, I think it would. I mean, clearly it depends what material you have, but if you have good cell block material, or indeed you could even do that with very good cellular material on the slide these days. If you could persuade your laboratory that does this sort of thing to scrape it off and do it, then that's something I would consider doing. Yes, but it's kind of early days. We haven't really started doing stuff like that yet ourselves, but it is something we're thinking about.
Yeah, absolutely. I think we've also literally just started taking kind of baby steps in this direction and using it has to be a very cellular sample, ideally with almost pure tumor population in good numbers. Our cytogenetics team prefers the PAP stained alcohol fixed smear rather than the Ginza stained slide. Of course, as you said, cell block would also lend itself to studying those, but it really does help if you're able to do the genetics on the cytology, and by chance, if you don't have enough material on the cell block, then it's a real cool if you're able to say, well, actually, we just did it on the direct smear. So That's great. Another question coming in about, did you grade the adenoid cystic carcinoma on cytology, low, intermediate, high grade, to direct surgical management, or doesn't it matter given the radiology?
Well, again, it's a presentation from Cornwall. I mean, so I can't answer that question about that particular case.
Yeah, again, it's a tricky one to answer, isn't it? I mean, it is possible. There is literature to sort of advise that, you know, you can actually try and classify adenoid cystic carcinomas into at least high and low grade based on FNA appearances. So yeah, it's possible to do it. As to whether it is, you know, individual practice or not, must vary.
I do it routinely myself. But
Absolutely. Thank you. I think those are all the questions we have, and a few compliments as well, which we will convey, no doubt, via Leonie to the radiology team in Cornwall.
Definitely I will. Thank you.
Okay, Leonie, I think it's over to you now.
Okay, thank you very much. The BAC were aware that there were sort of a few sites or scattered sites across the UK offering rapid on-site evaluation. And an example of this is Sarah Reeves' thyroid clinic that she started a couple of years ago in Kent. And so we've asked her to share her data, and she's kindly sent on. But just looking at her thyroid clinic that was installed, and Kent has got multiple sites, it's multiple hospitals. So she's got the luxury of comparing real time, basically rows, sample sites that have rows and the sites that don't have rows. And you can clearly see from her data that in 90 samples that the Thy1 category is significantly reduced in the sites that have rapid on-site evaluation. And on the next slide, please, Tony. You can, it's just another way of highlighting that in the adequate categories, the percentage of rows that is diagnostic or adequate is up to 89% where rapid on-site is provided. And when we implemented rapid on-site evaluation in our institution, we were looking at you know, thyroid as well, and we saw that it went up into the high 80s for adequacy. But not just adequacy, one of our key things was looking at how many times the patient has to come into hospital. Can they come in one procedure and we get everything in one go, particularly in other areas of the head and neck, not just, you know, outside of the thyroid. And at the time before we had rapid on-site evaluation, 42% of patients were actually having to come back because there was either insufficient material to do any IHC or molecular tests, or simply they just didn't know what to do with the sample, and, you know, most of the slides were too thick to actually get a good morphological assessment, or they just didn't do needle washings at all. So you're limited as to how with the diagnostic potential based on what the sampling is you received. So when we set out to implement rapid on-site evaluation, we realized very quickly that we couldn't support rows on every single FNA in the hospital. But what we did do was train all of our radiologists on what to do with the specimen. And that actually made a significant difference in itself. We told them about the importance of needle washings. We told them about putting small amounts on the slide so that it air dries quickly, so you don't get all the artifact, and not making it too thick. And this alone actually improved the quality and the diagnostic potential of the samples that we were receiving in the department. And then in the sites where we, in the clinics that we had implemented rows, we saw immediately that 93% of the time we were obtaining diagnostic material. But we had to go back to our original question. It's not just obtaining diagnostic material, it's going, is the patient coming in once, and do we get enough material, sufficient material, to do everything that they need from that one sample? And what we showed is actually FNA alone, we obtained sufficient material for diagnosis in about 75% of cases. But actually with rows being there, you could advise a biopsy. So for example, we don't have flow cytometry here. So in our lymphoma cases where you've got limitations on cytology, we would advise a biopsy if that was possible at the time. And or also sometimes in the oropharyngeal squamous cell carcinomas that have metastasized to the neck nodes, they can be really cysticky, and we don't get enough viable material for P16. So if we see this in rows, we also ask for core biopsy, and this brought our rates from 75% up to 93%. So we'd gone from 42% of patients having to return for additional tests or more invasive tests to literally 7% of patients having to return for additional tests. So it makes a huge, huge difference. Next slide, please.
Hang on. Yep.
So we were aware of all these different individual sites that were performing ROSE, but actually we wanted to look, the BAC wanted to get an appreciation of what was rapid on-site evaluation like across the whole of the UK. And so Dr. Paul Cross kindly gave us a sneak preview from the RC Path survey that went out last year, which was targeted at lead cytopathologists and histopathology leads. About we've pinched the ROSE section from this, and they had a really good response rate actually, and 73 labs across the UK did reply, and what it showed was 38% of labs across the UK do actually have a ROSE service, and there was an equal split between this being provided by biomedical scientists and pathologists, but the most common area for rapid on-site evaluation was seen in head and neck. And interestingly as well, that there's not many, sorry Karen, there's not many pathologists actually taking FNAs in the UK. Next slide, please. We also wanted to have a look at what the interest was from our biomedical scientist colleagues across the UK. So we launched a survey through the IBMS back in January and February this year, and we had 49 responses across the UK. And one of the questions also matched what we saw in the RC Path survey, that actually it was about 40% split with biomedical scientists only and biomedical scientists and pathologists in combination providing rapid on-site evaluation services. Next slide. Oh. Yeah. And we also wanted to look at how is it being applied, because as Tony mentioned earlier in the literature, people talk about ROSE and they throw the term around ROSE around quite a lot, but they don't actually say what are the steps involved and what are people doing and what are the assessment and what are the thought processes. And it seemed to be that there was a lot actually of the ROSE sites doing it for adequacy and sufficient sampling for ancillary and molecular testing, as well as staging. And the preliminary diagnosis at the bottom is probably reflective of the sites that have a pathologist in attendance. So we also asked what people felt about what were the challenges, what were the showstoppers in actually implementing ROSE. And as Tony had already alluded to earlier, it came down to resource funding, training and expertise. And in a few areas, sites saying that actually it wasn't supported locally or managerially. And some people had said it'd been impacted by COVID. They were trying to set things up, but they didn't have the clinical arrangement and the clinical setup to support targeting the right treatment. So it was a bit of ad hoc. And some said it was limited just to senior scientists and pathologists. Next slide, please. What was really interesting to see was actually there was an overwhelming response requirement that people were interested in training, and I feel that the BAC and my colleagues feel that collaborative training is really important in this approach, because we've already discussed that it's a collaborative process. Equally, when you come to writing your business cases, it's a collaborative process. When you set up the clinics, it's a collaborative process. You're involving your radiologists, your scientists, your pathologists, your surgeons, particularly in head and neck. And so we felt the training should reflect that, and it was the feedback in the survey was actually people would be interested in that kind of style of training. Obviously with the pandemic, we were looking at options of whether virtual training would be acceptable, and it seemed that a combination of virtual and local regional training would be preferred, and that's understandable. I mean, it's quite technical, it's quite a practical skill to be learning, and that comes on with hand-on experience and exposure to clinical situations. We also asked if the ROSE module was incorporated into the diagnostic specialist portfolio, would you be interested? And not surprisingly, 50% of the people performing ROSE were actually said that they'd already completed their specialist portfolio. But to be 37% actually said that they're coming through the system, and then they would be interested in ROSE. So this suggested to us maybe we needed a standalone module if we were going to look at a future training and competency assessment for rapid on-site evaluation. Next slide. So we've talked briefly about pathologists and BMSs providing ROSE, but what's actually the key difference? And the key difference is it's provided in documentation provided by the RC Path, the IBMS and the BAC. And the key difference is actually the pathologist can offer a preliminary diagnosis at the time, whereas a biomedical scientist can't. And what you have to ask yourself and tell yourself when writing your business cases is that crucial? Do you have to have a preliminary diagnosis at that moment, at that time, or can it come the following day, a few days later? And you probably find that actually in the majority of cases, it's okay not to have a preliminary diagnosis immediately. And we also showed, Tony also showed earlier, that it's actually recommended in the tissue pathways documentation now that biomedical scientists are actually more cost effective. And with the national shortage of pathologists, it may be that there's more biomedical scientists out there to provide these services. So Tony has already covered the, what you can do as a BMS, or what you can do as a ROSE in general, and it's about the adequacy assessment, the sufficiency for sampling and ancillary molecular testing. But there's also these hidden gems of being in the room. You capture a wealth of clinical information, and that sometimes gets omitted from the request forms. You can provide real-time feedback. So if the sample is particularly necrotic, you can advise them to sample a different area. But equally, if they're a trainee radiologist, it's great for them because they get immediate feedback on learning how to take FNAs, and they know then how to triage the samples properly, and they know how precious some of the material can be. And in some centres as well, it might be that it leads to the image management or an MDT discussion, a mini MDT discussion. For example, if we think it's lymphoma and we take a biopsy, that might support the radiologist who was thinking of doing a next step of a CT that involves the pelvis. And also, when you've got custody of that sample and you take it to the lab, you take ownership of that, it significantly reduces the turnaround time. It's not sat in a corner waiting for a porter to bring it to the lab. And you can sometimes save 1 or 2, 3 days, but equally your sample's fixed as well. So if you are going to go down the avenue of molecular testing, you know that your sample has been fixed immediately, and your DNA and RNA is the best quality it can be. Next slide. So very excitingly, this came out very recently. So this is the British Association of Head and Neck Oncology guidelines that were written in 2020 that have just come out early this year. And this is key and crucial if you're thinking of writing business cases or proposals for starting and implementing rapid on-site evaluation. But they've now stated that all ultrasound guided FNA aspirations, FNAs, should be subject to rapid on-site evaluation. So this is aspirational and probably quite frightening when you're thinking about how we're going to do this, but it's small steps and you will get there. And also the interest with reporting within 7 calendar days as well. So we thought, okay, next steps, we're talking about collaborative training, and so let's do this collaboratively. Let's engage with the Royal College of Radiologists, and let's get radiologists and cytopathologists and biomedical scientists all collaboratively talking and working together. And so and the same when you come to your case studies and business case studies as well. This isn't a silo service. This involves a multitude of disciplines that need to be working together to get the successful implementation into the head and neck pathway. So we are proposing this two-pronged approach, so that would involve the Royal College of Radiologists, but also the British Association of Cytopathology, we've sent out a survey similar to what we did with the IBMS to the Royal College of Radiologists, just to see what their ideas are of ROSE and would they be open to collaborative training as well. That survey is currently still running, but the initial results are in favour for supporting ROSE. They recognise it's a valuable entity, and 70% at the moment of the few returns we've had are actually really interested in collaborative training. And so it's hopeful that early summer this year we'll be doing some collaborative webinars through the Royal College of Radiologists about the entire pathway for head and neck cancer cases. Next slide, please. And also going back to what I touched on earlier about the ROSE module. So we've been working with the Institute of Biomedical Scientists to look at the possibilities of a ROSE competency and training module. And the reason, again, we're making it modular is because a lot of people have done their specialist portfolios, and this would be a nice complementary bolt-on. But also in laboratories like my own, where we had lost the cervical cytology service, we lost a lot of cytology expertise. So to make our ROSE clinics more robust, we've trained histology senior BMS staff, and they're doing it incredibly well. And so for people in histopathology as a background, it opens up this ROSE module as possibility for them as well. And this first module would be focusing on thyroid and head and neck. And so once we have more details about this, we'll happily share. So thank you very much.
Okay. So I'll stop sharing the screen now, I think.
Yeah. So thank you, Tony and Leonie, and Leonie's colleagues as well for that presentation. Again, really good. There's a few questions in there. I don't know. Yeah, that's right. Ash, no, I'll let you go. Yeah.
No, that's fine. I was just going to read out the question, which is the slide from the Barno, and one of the colleagues who has typed in says, please share with your histopathology and radiology colleagues who are Rose cytology hesitant or reluctant. So I think that's a great presentation actually to run for your radiology team as well. And then a comment about flow cytometry on needle washings to aid recruitment in cytology since the loss of gynae-cytology. And I think we've definitely seen, you know, the kind of shift from gynae, which we, again, you know, did not hold on to. So with that gone, we managed to retain all of our staff in cytology simply on the back of the FNA clinic work and on-site evaluation by biomedical scientists. And in fact, this might be a good opportunity now, if it's okay with Leonie and Tony, for me to just share a few words and our experience at Guy's and St. Thomas's that's in London, where most of the service actually numerically more procedures are attended by trained BMS than they are by pathologists. So as Leonie highlighted, pathologists are really required where provisional tissue diagnosis is required to be communicated to the patient through the physician or the surgeon. So at Guy's and St. Thomas's, where we still do actually breast core imprint cytology, even if it's not FNA cytology, but our breast surgeons are very keen to have a cytodiagnosis for their one-stop breast clinic. And so we provide that for breast, head and neck, and then also for EBUS, EUS, and interventional radiology, where a pathologist would go down to attend the procedure. And often the radiologists would like a pathologist to attend where a discussion is required whether or not to perform a core biopsy. So, I mean, historically, I think many trusts that have offered FNA service automatically provided rapid on-site evaluation even before that term was coined. If you were providing an FNA service, it was almost understood that you would be reporting on it, a little bit like a frozen section. And so I think what's needed to, you know, keep this going is, I think, requires clinical leadership and willingness by the pathology team to provide such a service. And then getting the resources are almost the next step. If you've got a good clinical argument and the keenness of the pathologists and the clinicians, and ideally, of course, now radiologists, then you've got everything, all the ingredients are there, and then finding the resources becomes easier. Because once the management actually does the maths, as they did in our trust, they immediately saw that there was actually, this was not expensive. This was going to save the trust a lot of money because they were going to reduce patient visits for results on another day. And we were also going to minimize non-diagnostic procedures. So that in itself was a financial argument, or those two were strong enough financial arguments to say, I think financially it is a goer. But of course, the clinical reasons are just as important. And improving the turnaround time for a tissue diagnosis is important, not just for the patient, but also to the clinical teams, and more importantly, to the trust for advertising their unique services and, you know, for their ratings for CQC and, you know, and peer review. For the clinicians, again, it allows planning other staging investigations for cancer patients, the PET, CT, MRI, often in time for ratification at the MDM, which might be at the end of that week, or, you know, just serves to gain time, sometimes up to a week. And that is something that they really, really are keen on. The patient feedback is positive, you know, so if you do any survey, 9 out of 10 patients would say, we would like our results the same day. Obviously, this has to be delivered in an appropriate setting with, provision for breaking bad news and having a, counseling team to hand. But also, I think as pathologists and BMS, it's just, I think, made us much more visible to clinical teams and their appreciation of our roles in clinical management. When MDMs first started, we began to actually meet our clinical colleagues much more regularly and frequently. And, the clinics are another opportunity to have a sort of a mini MDM before the case actually reaches the formal MDM where things are ratified. But there's the opportunity to get all of your clinical information firsthand. You get your macroscopic pathology, which is radiology in cytology terms. You get all of that upfront. You're in a much better position. You're much better informed to reach a conclusive cytopathological diagnosis. And of course, with having BMS on board, the massive improvement in the quality of the slides, the number of slides you need, the quality of the staining, smearing, appropriate triage, and sending things off while they're still fresh to the appropriate laboratories, whether it's microbiology, flow cytometry, or needing to go back to the laboratory, and also minimizing errors and mismatches between labeling and request forms and all of that. And it takes a lot of burden off the radiologists or the radiographers not to have to do all of these things. So, over the last 10 years, we have pretty much moved on to a no ROSE, no FNA service. So, now no radiologist will actually want to do an FNA on their own when they know that we're just a phone call away. Obviously, we still follow a kind of a booking procedure. So they do have to call the lab and arrange some things ideally beforehand. But they also know that we are moving to a, all day, every day service, so that there will be somebody on call or to hand to attend a procedure on the ward or an unexpected urgent case, whether it is being done by a radiologist. Only a very small percent, only about 10% of FNAs are now performed by pathologists. So the number of our palpable FNA work has gone down, but with BMS involvement and on-site evaluation, the total number of our FNAs has gone up tremendously. Okay, I'll zip up now. Thank you for giving me the time.
Well, thanks very much for that, Ash. I was able to scan some of the chat. There's been a lot of support for all of that. James Garvican says clinical leadership vital to get this off the ground and to establish training.
Sarah is one of our radiographers who actually takes the FNA, Sarah Martin, in the team. So yeah, we have not just radiologists, but radiographers are training to do the FNAs and biopsies.
That's brilliant. There was a question earlier on, which I was just scrolling back to, just about staining. I think what stain to use. I just say, I mean, we don't use Diffquick as in the trade name Diffquick, but we use a similar rapid Romanowski stain. There are rapid H&E and Papa Nicolau stains, but they do take. I mean, H&E is not recommended anyway. But Papa Nicolau, I've never used a rapid Papa Nicolau stain, but I think it takes 2 to 3 minutes. And there are a lot of stains to do. There's a lot of pots, and some people do that, but I don't have that much energy, so we use a rapid Romanowski.
I think one of the sort of anomalies, I suppose, that still remain across a lot of UK-based laboratories is the continued use of the H&E stain, although it isn't a recommended stain for cytology, simply because it was developed as a stain for paraffin-embedded formalin-fixed material. But a lot of cytopathologists who practice cytology are sort of H&E morphologists, and I think they feel comfortable with the same colors, but bearing in mind that it isn't actually a standard stain and it wasn't really developed to be used as a cytology stain, and the college guidance is against it. I would say, if you're comfortable with an H&E, you would be comfortable with a PAP, because they're both hematoxylin-based dyes. Where you're looking at the nuclei, it is still hematoxylin. So if you're able to validate a Papa-Nicolau-based stain in your laboratory, we would strongly recommend that you switch to that rather than continuing to use H&E. I realize that a lot of colleagues are very, very much used to the H&E and don't want to give it up, but it isn't really the best stain.
I would second that. I mean, I occasionally have to review H&E stains on air-dried preparations, and they do always look very washed out. And a good Papa-Nicolau assay, and you can rehydrate, if you want to rehydrate an air-dried stain and then stain it with a Papa-Nicolau stain, that will tend to produce better results than H&E will.
Comment here from colleagues, just reminding us that digital cytology is here as well, and will be very useful for remote ROSE cytology, particularly in light of the shortage of specialist cytopathologists. And this is already quite widespread practice across Europe and also in the States.
Yeah, I mean, they have a whole network up in upstate New York, don't they? They're based around the Memorial Sloan Kettering, that kind of thing. And yeah, I'm sure that will become more widely used, yeah.
I think it would be good for training as well, because one of the biggest learning curves of being a ROSE is actually exposure in the clinical environment, and then that big step when suddenly no one's there to hold your hand anymore. And yet if you've got a digital platform to be able to go, I'm really not sure on this, then you've got that backup support if required or needed, or equally for complex cases where you need to involve a cytopathologist.
Yeah, I agree.
Got some great points here from Gilda Santos. She says, we've been working with radiologists more than 20 years. And one of the benefits for radiologists is that pathologists can provide feedback about the technique in performance of good FNA, because some of them didn't really have very good training to start with. And I certainly know that our radiologists really, really want us to be there, because it is a very good guide to just honing their own skills and also assist them with their radiological diagnosis, particularly if you're able to offer a tissue diagnosis. It just makes it easier for them to interpret the ultrasound just in the same way as we benefit by knowing the ultrasound findings to interpret cytology. It works both ways, and I don't think we should feel embarrassed to admit that, having on-site evaluation, either just for adequacy assessment, which means you can minimize the number of passes you're going to take from the patient, but having a provisional or a preliminary diagnosis by a pathologist really helps out radiology colleagues in also making more robust ultrasound-based diagnoses.
Mm-hmm.
I like James Garvican's comment about clinical leadership being vital to get such services off the ground into established training. But then the clinician needs to get out of the way to allow the roses to flourish. Love that.
Yes, I noticed that Gilda as well has Brian Collins, who published quite a few papers, didn't he, in the States about essentially time and resources and that kind of thing, and showed that there was a saving in both time and money, because you essentially ended up with fewer slides and therefore reduced time overall. And I think that's absolutely right.
I think it takes a good service manager to be able to do the business case and the whole sort of financial aspect of it convincingly. Obviously, we would be there to provide some very strong clinical arguments for why this is helpful and useful. But actually, if they do the maths properly, they will be able to demonstrate how much the savings are. And then that business case really becomes inscrutable. You can't turn it down, because there's both cost effectivity and clinical effectivity. And I think we really sort of gained from getting our first business case off the ground. And then after that, all the others came on top of that, or on the back of that. And it was much easier to get them through, because once we started off with the breast clinics, we showed the advantages of retaining a one-stop breast cytology service, which effectively was sort of dying out across the country. And there's only a handful of trusts across the UK that have managed to maintain that. But then on the back of it came, EBUS, and then on the back of that came head and neck, and then EUS. And then the same business plan really was just used to fund more posts for pathologists, for BMS, and now for radiologists, because now the radiology service has also become so much bigger that the business case becomes even more strong to appoint dedicated head and neck radiologists to be able to service such clinics. So it's a win-win situation for the whole trust, but it takes someone to just write that good business case.
I agree, Ash, and we found similar things here where we actually mapped out the model in the thoracic care pathway, and how much more expensive it was if people had to keep coming back for repeat procedures. And that's what I alluded to earlier with our one procedure, getting everything in one procedure, and they're the kind of audited data that we showed to our finance teams and our procurement teams in our business cases, and they could see it's a no-brainer, isn't it? If someone's coming once, it's going to be a lot cheaper someone coming 4 or 5 times and having to have more invasive procedures, and sometimes ones that require GAs or overnight stays, and that, I agree, it's key to put all of that information in your business studies.
Okay, that's great. Has anyone any further comments or questions for our panel? Looks like we don't. So I'd just like to thank all the presenters today for taking the time to prepare and present. Again, I think it's been a very successful session. So I just made the thanks on behalf of the BAC and also for all the participants that have logged in today. It's great to see everyone. And again, we do get a high uptake with our webinar, so we're delighted about that. You will see in chat there is a link if anyone is interested in membership of the BAC. Then we would obviously encourage anyone to become a member, and the link is there in chat, but you'll also be able to find that on our website. And also there's just a link there to our next webinar, which will be on Friday the 23rd of April. Ash, I don't know if you want to say anything as well, just to close off the spring tutorial.
Sorry, Alison, I missed that.
I just wondered if you wanted to say a few words just to close off the spring tutorial.
Oh, that's very kind of you. You're the meeting secretary. I just do what you tell me to. You're the boss. So no, thank you, Alison. Thank you, Christian, and thank you to all the presenters. And I think this is a meeting not just for UK BAC members, but also for our overseas colleagues, and having these collaborative meetings has seen an exponential rise in the attendance of all of our meetings all the way through last year. And the BAC has certainly, tried to keep up and provide teaching and training when it was so sadly missing, particularly for our junior colleagues coming up to the exam and not being able to get sort of live one-to-one teaching. So we will continue to keep up the good work. Thank you all for your support. And yes, thank you all members of the BAC and everyone who joined in today. Thank you all. Have a great weekend.
Thank you.